Okay, hello, I'm back, and this is my second lecture, and this is going to be a little bit different than the first lecture. Hopefully you watched the first lecture, but today I want to be talking about Suboxone and other opiates and kind of how they work on your brain, and give you a little information regarding Suboxone, and try to just give you a little bit of education about how things work, and hopefully give you a better understanding as to, if you were planning to come off of Suboxone, how you might do that successfully. So why don't we go ahead and get started. First of all, what I want you to understand is that when we talk about opiates of any kind, they get classified into different categories. One category would be an agonist. And an agonist is an opiate that will stimulate the receptor in your brain that connects with opiates fully. So what an agonist does is it fully stimulates the mu receptor in your brain. So what's an agonist? Let's see, examples of agonists would be heroin, methadone, Vicodin, hydrocodone, oxycodone, fentanyl, those types of medicines that people you may hear are taking them for pain management, those sorts of things. And when you take those, what happens is that those medicines get absorbed into your body, and then they go up to your brain. They find the opiate receptor in your brain, they bind onto it, and then that's what causes you to have the effect of the medicine. So for instance, if you're having a lot of pain and I gave you hydrocodone, you take the hydrocodone, and hydrocodone will make its way up to your brain, find the receptor, bind onto it, and you'll feel less pain. That's a fairly simplistic explanation, but that's what's going on. And that's what agonists do. There's another group of medicines called antagonists. And examples of antagonists would be naloxone or naltrexone. You may have heard of these. This is a fairly common thing that's been used in ERs for many years. When somebody comes into an ER and they're overdosed, let's say that they've overdosed on heroin, they would give them naloxone, and what naloxone is very good about doing is going into your system, going up to your brain, and then whatever is on the opiate receptor will kick it off and close that receptor, so that if you're overdosed and not breathing and you get naloxone, what it will do is reverse the overdose. Naltrexone is another one. It's a longer acting kind of form of naloxone. It'll do essentially the same thing. So just so we understand, the agonists are full agonists, go to your receptors and they open the door all the way and you get a full effect. And the antagonists, all they do is they go on the receptor, block, kick whatever's on the receptor off or block it, and don't let any effect happen. So it's kind of like, if you want to think with me a little bit as far as a door, if you have a door and it has a keyhole and I put a full agonist, imagine the full agonist, methadone, heroin, whatever, being a key that goes into that door. It fits very nicely and it opens that door all the way open. That's what a full agonist does. Antagonist would be like a key that will also fit into the door, but it's kind of like a broken key. So you put the key in the door, and all it does is basically block the keyhole, and it doesn't open the door at all. It just blocks the keyhole. And so you don't get a door opening, so you don't get any effect. You just get a blocked receptor. And that's what an antagonist does. And so because of those two different effects, you can see why, if you were to have overdosed, having an antagonist go onto the receptor is going to probably save your life. But I wanted to then spend a little bit of time discussing what Suboxone is, and that's called a partial. Yeah, it's kind of getting a little bit crowded on the board here, but it's a partial agonist. And some people would say it's a partial antagonist as well. So either way, but what it does is, imagine Suboxone as being a key that you put into the door, And what it does is it's not as good as an agonist, so it's not going to open the door all the way, but it's only going to open the door halfway. As a matter of fact, Suboxone likes doors to be opened halfway. That's what it does. It keeps the door opened halfway, so you don't get the full effect, but you do get some effect, okay? And so that's what Suboxone does. The other thing that's peculiar or interesting about Suboxone is that it has a very, very high affinity for the opiate receptor in your brain. So what do I mean by that? So if I were to have an example of musical chairs, for example, let's say that I have one chair sitting right here and there's two people fighting for that chair. Whoever's the bigger and stronger person is probably going to win out and get to sit down in the chair. And so in your brain, when you have receptors in your brain and all these chemicals are floating around, sometimes opiates or different chemicals can compete for receptors just like you would compete for a chair. And so if somebody is stronger, if a chemical is stronger than the other, it's going to win out and get to sit down on the chair. And of course, when you get to sit on the chair, then you get to produce whatever effect you have on that chair, or kind of like the example I was using in the past, if you're a stronger chemical and you get to put your key into the door, you get to do to the door whatever you do, and whatever chemical that got kicked off or didn't get into the keyhole is like left out there with nothing to do because it doesn't have a receptor to effect. I hope I'm making sense here. So that's the peculiar thing about Suboxone, and that's why we can use Suboxone in an outpatient setting to treat people with opiate dependence in an outpatient setting because it's safe. Okay, so what I mean by a safety profile is that this medicine's been designed, or some of the qualities of the medicine are particularly good as far as not having people overdose or have other problems while they're using it. And basically the reason why is that Suboxone produces a ceiling effect, and a ceiling effect is basically you get to a point where regardless of how much you may take, it's not going to do any more than what you've already experienced. So for example, the ceiling effect for Suboxone may, let's say, be around 16 milligrams. And after 16 milligrams, even if you took more and more and more, you're not really going to get much benefit because it just can't really find any new receptors to do an effect on, and they only open the receptors halfway. So, for instance, if you were to take something like heroin, which has no ceiling effect, and you took, let's say, 1 gram, you may, and let's just say that you're looking at somebody's breathing, and so you take 1 gram of heroin, and the breathing, you start having more and more breathing problems. So let's say this is breathing problems. And so then if you took, that's at 1 gram of heroin, and then at 2 grams of heroin, your breathing problems go up, and then at 3 grams of heroin, your breathing problems go up. And it just keeps going up and up and up like that, and then finally you're not breathing. And that is a big problem, as you probably could imagine. What Suboxone does, let's say that at 8 milligrams of Suboxone, the breathing, starts like this, and you're maybe, I don't know, you probably aren't really experiencing any breathing problems with Suboxone, but just for example's sake, let's say your breathing is affected a little bit, and then at 16 it's affected a little bit more, but then after 16 milligrams, even if you took a lot more of Suboxone, your breathing is not going to continue to become a greater and greater problem. This is the ceiling effect, this flattening out. And all that's saying is regardless of how much you take after a certain amount, it's not going to cause any more problems, and that's why it's really a pretty safe medicine to use, is because I'm not real too concerned about overdosing somebody on Suboxone. The other thing that they've done with Suboxone is that they added naloxone into it. Again, remember the antagonist medicines we were talking about earlier? Well, naloxone is also part of Suboxone, and because of that antagonist part of it, it blocks receptors, and so it actually can make that sealing effect. If you were to actually try to inject Suboxone, it can make the sealing effect even lower because it's just going to bind to receptors and not let you have any more effect. But there is a little bit of a misunderstanding about Suboxone, in my opinion. I think that there is some risk with Suboxone. People are talking about not being able to overdose on Suboxone, which I'm not 100% sure I agree with that. Suboxone has naloxone in it, but what's interesting about that is that Suboxone is actually a stronger, again, going back to the musical chair analogy, Suboxone will fight for a receptor stronger than naloxone. So if you were to use Suboxone and you were to somehow figure out, hey, I want to inject this, you're actually not going to get much of the naloxone effect, and you're going to get more of the buprenorphine effect, because it's just a stronger affinity for the receptor. And that's why I'm not so sure people understand this point, but you're actually not going to get much of the naloxone effect. And so I know that's why they put naloxone in the medicine, is to try to prevent people from injecting, but it's a dangerous thing to do, is basically what I'm saying. Don't necessarily think that you could not overdose on Suboxone. I think that you possibly could, because again, the buprenorphine or the Suboxone piece is stronger for the receptor than the naloxone piece, and so you could actually overdose. Now, when we're talking about overdosing as well, the sealing effect is all nice and good, but if you start adding on other sedatives, and what are sedatives? Alcohol is a sedative. Xanax, Klonopin, Valium, Librium, all the benzodiazepines, Xanax. When you add those to an opiate, and I would include Suboxone, buprenorphine with that, all bets are off. As far as that sealing effect I drew, where it goes like this, if you add a sedative to Suboxone, that sealing effect can be bypassed, and you could quit breathing. And so that's why it's so important for people that are using Suboxone to understand, is that they can still overdose if they were to combine this with certain medicines in a certain amount. And so you got to be very careful. Now, at the beginning I said I would talk a little bit, and this is what I'll end this lecture on, is about coming off Suboxone, or how do I get off Suboxone. Once I get on it and I'm stable on it, and now I want to come off of it, how should I do that? Well, the best way in my opinion to do that is, don't even consider doing it if your life's not stable and you don't have a lot of supports and you haven't worked on a recovery program. I mean, you will need extra support when you're coming and weaning off Suboxone, okay? It's not an easy thing. I wish I could say, you know, it's very easy to come off Suboxone, but it's not. It takes a little bit of time, it takes a lot of effort, and you should probably keep in mind that the slower you go, probably what I've seen is that people have had more success if they go a little slower. So let's imagine somebody's on 16 milligrams of Suboxone and they come in and say, I want to get off. I want to be done with this. And what I would say to them is, okay, well, let's just think about a time frame as to when you want to do this, and then start dividing the dose a little bit each month to come down and give your body plenty of time to readjust to new lower doses. So if you're on 16 milligrams, I probably would say coming down 2 milligrams every 1 to 2 weeks is a really pretty quick wean. So if you're on 16 milligrams and at the best you came down 2 milligrams every 1 to 2 weeks, it's still going to take you a month or two to get off of this completely. So a lot of people want to get off like in a month, you know, in a week to a month, but I would think that trying to stretch it out over a couple months period, most people have better success doing it that way. There's not really a wrong or a right way to detox or wean yourself off Suboxone. The only thing that I would tell you is that what I've seen people do that have been most successful is one of two ways. One is going down slowly and just kind of giving themselves time to readjust to the dose. And the people that are really, really motivated to get off quickly, the best way to do that is probably to come down a little bit on your own, but then when you get down to, let's say, 8 milligrams or so of the Suboxone, what I've seen people do that have been successful is go into an inpatient setting, like at Fairbanks or Community North or somewhere like that, and then they, in a week, get off the rest. You just need that extra support, and they can give you other medicines and they can monitor you during that time, and that's what people have done and have totally gotten off the Suboxone altogether. So I don't know if those options are, I would imagine the first option is the one that's most available. The second option, if you're wanting to go faster, may be available or may not, depending on insurance and money and those sorts of things. I'm trying to think of anything else I want to talk to you about with regards to Suboxone. You know, the last thing I would want to say is that if you've really had a struggle in the past with your opiate dependence and have tried to get off, and there's a pattern where you get off and then you continue to use and you relapse and life gets really, really bad for you, really be careful in considering getting off of this. This is, in my estimation, something that could be easily taken for the rest of your life. And I've always said this, and I don't know if I've said this to you, if I've known you, if this is the first time we're meeting, then I haven't said this to you, but I've always said my bottom line for somebody is that they're doing well, that they're functioning well. And that's really what we're concerned about, is that you're functioning well. I don't care if you're on or off something. I just care that you're doing well and you're living your life to its fullest. So detoxing is something for people that want to do it, but it's not something that I ever particularly force somebody to do, because I don't think that that's necessarily the right way to look at this problem. I think that if treatment is working for you and you're happy with it, then I'm happy. If treatment is working for you and you want to come off of that, I would work for you to help that happen. And so I know there's a lot of pressure from outside sources to make somebody do one thing or the other. But in your heart of hearts, ask yourself, is this really best for me? And if it is, then just, talk to me, talk to your provider, and go ahead and try to wean yourself down. But if you're really like, my history has been so terrible that every time I've tried to get off or I have gotten off, I've relapsed and I've messed my life all up in many ways, then it may be best to just maybe consider staying on this for long term. So those questions are best answered by you, and I'd be happy to talk to you more about them if you have those questions when you come to see me or if you see Dr. Kilgore. So thanks again for listening, and bring questions in with you if you have any to your next appointment.